Let's talk about ITP. So thrombocytopenia results from one of the three processes. One is decreased bone marrow production, sequestration usually in enlarged spleen, and or increased platelet destruction. That is, this disorders of production may be either inherited or it can be acquired. The key step is to rule out pseudothrombocytopenia, particularly in a patient without an apparent cause for thrombocytopenia. So pseudothrombocytopenia is an in vitro artifact resulting from platelet agglutination via antibodies, usually IgG, when the calcium content is decreased by blood collection in EDT. So decreased production of platelets, that is congenital bone marrow failure, that is Fanconi's anemia, Wiskott-Aldrich syndrome. So what is the triad of Wiskott-Aldrich syndrome? I'll give this to you as homework. Find out and read. Acquired bone marrow failure, there is aplastic anemia, myelodysplasia, exposure to chemotherapy, irradiation, marrow infiltration by neoplasm or infectious diseases, and nutrition. There is increased destruction of platelets like thrombocytopenia, including hepatitis C and HIV-related drug-induced, heparin-induced thrombocytopenia, TMA, DIC, post-transfusion purpura, hemophagocytosis, neonatal alloimmune thrombocytopenia, von Willebrand disease, and mechanical. Increased sequestration of platelets, hypersplenism, example are related to cirrhosis, myeloproliferative disorders, and lymphoma. Other conditions causing thrombocytopenia are gestational thrombocytopenia, Bernard-Soulier syndrome, gray platelet syndrome, May-Hegelin anomaly, pseudothrombocytopenia. Algorithm for evaluation of thrombocytopenia: platelet count less than 1.5 lakhs, check the hemoglobin and white count, WBC count. If it's normal, check the peripheral smear. If it is fragmented blood cell, the diagnosis goes towards microangiopathic hemolytic anemia. If the peripheral smear shows normal RBCR morphology, platelet normal or increase in size, consider drug-induced, infection-induced, idiopathic immune thrombocytopenia, congenital thrombocytopenia. If the hemoglobin and WBC count are abnormal, do the bone marrow examination. If platelets are clumped, read in sodium citrate or heparin. This is not related to ITP, but it is very important MCQ, so I'm covering it here. Some antibiotics and antivirals that cause thrombocytopenia are quinine, quinidine, penicillin, cephalosporin, vancomycin, trimethoprim, sulfomethoxazole, sulfonamides like sulfonylureas, linezolid, very important because in certain orthopedic infections they prescribe linezolid for a long period of time, and if not treated or if not recognized, it can cause permanent bone marrow suppression. We had two patients which were treated for osteomyelitis velloinosis for almost 5 to 6 months. It caused so much bone marrow suppression that we had to give colony GSF stimulating factor for almost a period of 1 year for the bone marrow to pick up. Valcyclovir, ganciclovir, indinavir, cardiovascular medications like apixaban, tirofiban, eptifibatide, salicylates, digoxin, and furosemide. Miscellaneous like cimetidine, ranitidine, famotidine, valproate, and interferon. So this slide is something you're supposed to revise just one day or day before the exam because it's very volatile and it's very important. If you see this, you will remember. The incidence of ITP is 50 to 100 cases per million per year. Children accounting to half the cases, mean the adults is 50 to 55 years. The diagnosis of ITP is a diagnosis by exclusion. I'll brush up through the important points of the topic. So newly diagnosed is up to 3 months since diagnosis. Persistent is 3 to 12 months since diagnosis, and chronic is more than 12 months since diagnosis. Severe ITP refers to ITP with bleeding symptoms sufficient to require treatment. This typically occurs when platelet counts are below 20,000. Refractory ITP refers to ITP that has failed to respond to or relapsed after splenectomy and is severe, associated with bleeding or bleeding risk that requires therapy. So ITP can be divided into acute and chronic. Acute, more commonly seen in children, may follow infection or vaccination, usually runs a self-limiting course up to a period of 1 to 2 weeks. Chronic ITP, more common in young and middle-aged women, tends to run a relapsing and remitting course. So difference between acute ITP and chronic ITP. Age is usually 2 to 6 years, it is 20 to 30 years. Sex is any, predominant in female in case of chronic. Onset is acute in acute ITP, whether it is chronic in case of chronic ITP. Previous infections is common in case of acute ITP, that is unusual in case of chronic ITP. Platelet count is usually less than 20,000 in case of acute ITP, more than 20,000 in chronic ITP. Remission is common. Less than 20% in case of chronic ITP. Duration is 2 to 4 weeks. Chronic, it is months to years. So the bleeding, the clinical presentation is excessive bleeding with minor injuries, spontaneous bleeding from mouth and nose, unexplainable or spontaneous bruising, ecchymosis petechiae, hematuria, menorrhagia, intracranial bleed, purpura, and thrombocytopenia. So this is ecchymosis and petechiae. So what are the size of petechiae and what are the size of ecchymosis in homework for you? Very important. I want every one of you to know that. So when to do a bone marrow examination? Bone marrow examination can be reserved for older adults, usually more than 60 years. Those who have other signs or laboratory abnormalities not explained by ITP, in patients who do not respond to initial therapy, megakaryocyte abnormality and hypocellularity or hypercellularity are not characteristics of ITP. So management is prednisolone 1 mg per kg per day for 7 to 10 days, following rapid PrEP or dexamethasone 40 mg per day orally for 4 days monthly for 6 months. IVIG 1 gram per kg per day IV for 2 days. And anti-D 75 mcg per kg IV for 1 dose. Platelet transfusion if there is bleeding. Persistent or worsening ITP, you can add mycophenolate mofetil, azathioprine, danazol, cyclosporin or chemotherapy, and autologous transplantation or splenectomy. So ITP in pregnancy, the goal of management of pregnancy-associated ITP is a platelet count of 10 to 30,000 in first trimester, more than 30 during second or third trimester, and more than 50 prior to cesarean section or vaginal delivery. Moderate oral dose prednisolone and intermittent infusion of IVIG are standard modalities of treatment. Response after initial therapy of steroids, that is complete responders, when platelet count is more than 1 lakh, partial responders when platelet count is around 50,000 to 1 lakh, and non-responders when platelet count is less than 50,000. So these are some new terminologies. One is complete response, partial response, and no response. A platelet count greater than 1 lakh, measured on 2 occasions, more than 7 days apart in the absence of bleeding. This is platelet count of greater than 30,000 or a two-fold increase in platelet count from baseline, measured on 2 occasions, more than 7 days apart in absence of bleeding. No response is less than 30,000 or less than two-fold increase in platelet count from baseline or presence of bleeding. Platelet count measured on 2 occasions, more than 1 week. Loss of complete response is platelet count of less than 1 lakh, measured on 2 occasions, more than a day apart, or presence of bleeding. It is less than 30 km, two-fold rise in platelet count from baseline, or a presence of bleeding. Platelet count is measured on 2 occasions, more than 1 day apart. So fostamidine is a recent FDA-approved drug for patients with chronic ITP who have had an insufficient response to previous treatment. It's a splenic tyrosine kinase inhibitor. It inhibits phagocytosis, reduces the antibody-mediated destruction.